He is TMJ surgeon, Dr. Ed Zebovitz. I've got a question for you. If you're a patient that wakes up in the morning and you can't get your jaw open, what do you have to say about that?
So that's concerning for obvious reasons. One, it's anxiety provoking for the patient, but my concerns are joints get their nutrition by movement. Yeah. So if a jaw's not moving, then it's not getting its nutrition, and subsequently, bad things can happen. So
orthopedically.
Thank you. So the cartilage can break down, you can start losing bone in the joint, you end up with both structural and mechanical problems.
Also on the bite itself.
Exactly. So the thought is in my office, that's a semi-emergency, meaning if they call, then I'm going to make a point to get them in as soon as I can.
And what will you do for that?
So the thought is listening to, of course, the story. So they wake up prior, usually the story goes is, I could open my mouth, but it would click when I opened. Yeah. I woke up in the morning, it didn't click, and I couldn't open.
Right.
So what that tells me is that prior to that, the meniscus was out of place. They probably had it throughout the night. An episode where they were doing some clinching. The tissues inside the joint all the fluid gets squished out, and it gets kind of sticky and stuck.
Sure.
So now in the morning, they're stuck.
Yeah.
So it's the fact that the meniscus, the disc, is out of place that's causing the problem. And I usually think it's because it's kind of stuck. There's little cobwebs or adhesions inside the jaw joint that's preventing it from moving. So the goal would be they need to get the jaw moving for obvious reasons.
And what kind of treatment would you initiate?
So typically it's one, again, I'd like to get it done as soon as I can.
Sure.
There's a couple easy things we can do. We can attempt to see if we can decompress the joint by putting cotton rolls in the back of the mouth, and then have them hold pressure up on their chin, and the thought would be that will move it down, and then try and have them open. So it's an easy thing. You don't lose anything by doing it. You have them in the office, a great thing to try.
Back around your second molars?
Second molars, and then firm pressure, so they go into the thinking position.
Sure.
And they hold it for about 5 to 10 minutes.
So you're distal, you're beyond past like the master insertion.
Exactly, and hopefully you're creating some space within the joint.
I got you.
So that's an easy thing, and you don't lose anything for trying.
Might be that easy.
Exactly, especially if it's in a recent event.
Yeah.
But my concern with those cases are they can relock again.
Sure.
So my workhorse for that, the procedure that I found to be the most effective is a procedure called an arthrocentesis.
Sure.
And if there's basically by putting a needle under sedation, because it's not a fun procedure to do, awake, while they're asleep, you put a needle into the joint, and you actually get into the joint, there's a compartment in there, and you just inflate it with fluid. Yeah. So by inflating it, you end up basically breaking up any scar tissue and things that are there. So
flushing it out.
Flushing it out, and then releasing these little cobweb scar bands. So once you free them up, so now the jaw can move. Mm-hmm. The concern is they can get restuck again.
Yeah.
So what I want to do is I want to put something in between there, a layer of fluid, and the best thing I can do is if that fluid can be both an anti-inflammatory, something that helps with healing, and actually separate the tissues, that would be a great thing.
So what do you use?
So classically we used to use steroids, but steroids have their net effect or can have a deleterious effect on the joint.
Sure.
So my favorite is platelet-rich plasma, which means when I start the IV, I draw some blood, I spin it down in the centrifuge, and then I harvest the platelets. And we use it in orthopedics and other things, and it's a wonderful way to help.
The patient's own
blood and platelets. So then I'll re-inject that into the joint.
Interesting.
From doing that, so now after that, they're opening wide again. We keep them, making sure that the jaw's movement.
And if we're lucky, that's all they need.
That's all they need.
Yeah.
So, but the key is to kind of address it early, because one, the cartilage needs nutrition, and the only way that cartilage inside the joint gets nutrition is movement. So if the jaw's not moving, then tissues die.
So we got to get it moving again.
Exactly. The other is the longer it's been adhesed or stuck, the more tenacious this adhesions, the cobwebs get.
So if this happens, get looked at quickly.
Exactly.
That's the key.
So, and when we look at it, so a lot of times we'll come to a general dentist and it must be an occlusal problem, so they'll put an appliance in.
Yeah. It's not always about the bite though.
It's not about the bite. So it's really that you have something going on inside the joint, it's mechanically stuck. So getting it moving as quickly as we can, and literature says if you get it done earlier, it's better. They resolve faster.
Yeah.
If you combine appliance therapy with an arthrocentesis, you get even better results than doing one or the other.
Interesting.
And then the other is the longer you wait to do it, the more muscle problems you're developed. Because if you haven't opened your mouth for 3 months, all the jaw muscles, everything have shortened. So when you can move it,
Not a good
it
thing.
doesn't move as well. So now you have muscles that aren't moving, that have fibrosed and shortened. The joint is harder to get it moving.
There's no excuse. Don't wait.
So, and this is sometimes where we always like to image the joint, but there may be a situation if the story is very clear that I'll go right to an arthrocentesis
I hear you.
rather than maybe the problem of getting it scheduled for the MRI and have to wait a week, 2 weeks, whatever to get it done.
Yeah.
So if we have I'd always like to have an MRI, but if not, if the story and all the components fit, then I will go right to an arthrocentesis.
Very good. All right. Thank you very much.
Thank you.